Hello everyone, myself Dr. Pratik. So today we will discuss about facial nerve palsy and related disorder. In the last lecture we have discussed about facial nerve anatomy. So now we will discuss about facial nerve palsy. So first lesion is Bell's palsy. Very common, very common. And examination point of view, very important. It's an idiopathic facial nerve palsy. Whenever patient is having facial paralysis but no definitive cause be found, then it is known as Bell's palsy. I mean, there is no history of ear discharge, if there is no history of any trauma to the facial nerve, if there is no history of any surgery. So it happens that facial paralysis develops automatically without any defined reason, then it is known as Bell's palsy, and it is the most common cause of facial paralysis. I'm talking about the peripheral facial palsy. You know, central facial palsy is very less common. Peripheral facial palsy lesions are more common as compared to the central one, and out of that, 2/3 of the peripheral lesions are because of Bell's palsy. And the risk increases in the pregnancy, especially in the third trimester. And what are the viruses that can be found associated? Either herpes simplex or Epstein-Barr virus. And the risk also increases with diabetes. So Bell's palsy, if the cause is not found, it is an idiopathic disease. There are certain etiologies that can be relatable to the Bell's palsy, like presence of some virus like the Epstein-Barr virus or herpes simplex virus, or exposure to extreme cold can result in Bell's palsy, and these risks can be increased in pregnancy or diabetic patients. Now, just to recall about the facial nerve anatomy, it starts in the brain from the pontomedullary junction, then it enters into internal auditory canal, exit from this canal, makes a sharp turn which is known as first genu, and from this first genu, that is a geniculate ganglion, greater superficial petrosal nerve arises, which gives secretomotor fiber to the lacrimal glands, nasal glands, nasal mucosal glands, or the oral or pharyngeal mucosal gland. Then this facial nerve runs into the temporal bone in the middle ear. In the middle ear, it makes a horizontal part plus vertical part, and before at this junction, it makes a second genu. This second genu, and in intratemporal part, that is a part of the facial nerve in the temporal bone, it basically gives three branches. The first part is the GSPN, that is a greater superficial petrosal nerve. Second branch is a nerve to stapedius, and the third branch is chorda tympani. And this chorda tympani now then relay in the submandibular ganglion and supplies secretomotor fiber to the submandibular and salivary ganglion. And this chorda tympani also responsible to carry taste sensation from anterior 2/3 of the tongue. Okay, so and then this facial nerve exit from stylomastoid foramen and gives multiple motor branches to various muscles like stylohyoid, posterior belly of digastric, and the facial muscles. Just to recall, now see Bell's palsy, what are the symptoms? The clinical features, look at the face. Suppose left-sided facial paralysis is there and the diagnosis will be made out as the Bell's palsy. So what are the symptoms? There will be drooping of the eyelid. So there is a complete paralysis of the half of the face. Because Bell's palsy is a peripheral facial palsy, so there will be complete half side of the face will be paralyzed. So what will happen? You can't just raise your eyebrows because the motor movements are lost. There will be dropping of the eyelids. There will be less lacrimation, so will be either apifora or dry eyes. Why dry eyes happen? Because the GSPN nerve, the greater superficial petrosal nerve, which carries secretomotor fiber to lacrimal gland, so its function will be lost and there will be less lacrimation leading to dry eyes. So patient will have dry eyes, dropping of eyelids, nasolabial fold. See, this nasolabial fold will be lost. There will be dropping of the angle of the mouth. You can see here the mouth angle will get dropped. Whenever patient try to smile, so only one normal side movement will be there and this side will be like a poker face because there will be no movements. There will be forehead wrinkles will be lost. These all things happens over the affected side, and patient may feel hyperacusis. Hyperacusis is to hear his own sound bit louder. Why does hyperacusis happen? Because the nerve to stapedias, which is a branch of the facial nerve which supplies the stapedial muscle, and what does it its role? It helps in impedance. That means it restricts the extreme vibration of the stapes bone, extreme vibration transmitting into the inner ear. So thus it protects the inner ear. So whenever this nerve to stapedius muscle function is lost, so the extra loud sound will cause the more vibration of the stapes bone, and that will get directly transmitted to the inner ear, and patient will hear louder sound. So hyperacusis will be there, decreased hearing, loss of nasolabial fold, and anterior two-thirds of the tongue. Over the affected side, the taste sensation will be lost. This is because of the chordae tympani affection. Okay, we know this is the third branch of the facial nerve in the intratemporal part. So loss of taste to the anterior two-thirds of the tongue, and sometimes there will be dribbling of the saliva from the angle of the mouth, just because the muscles become lax, they can't contract properly, so saliva will get dribbled from this angle of the mouth. So certain symptoms. Why I am telling this? Because examiner has been asked multiple times about these symptoms. So what is the cause, how progress, and what is the treatment, etc. Now, the Bell's palsy diagnosis is by exclusion. That means no other pathology, if not found, then the treatment diagnosis is said Bell's palsy. So what do? Start. The mainstay of the treatment in Bell's palsy is steroids. We will give prednisolone in the dose of 1 mg per kg per day. That is the only proven therapy. Steroids. Why steroids are preferred? Because we believe that in Bell's palsy, because of any cold or viral or something and some unknown factors, there will be edema of the facial nerve, and facial nerve this completely runs into facial canal, a thin bony canal. So any little edema in the facial nerve will, if it happens, any edema, so it's in a restricted area and restricted canal, so there will be paralysis of the facial nerve. So steroid will decrease that edema. So only proven therapy is prednisolone, and it should be started as soon as we discover the facial paralysis, and the dose is 1 mg per kg per day. So we will give it for the 10 days if patient is getting benefit. If not completely getting benefit, then you can extend it to 20 days or 30 days maybe. Okay. Now, then we can start with the antiviral. But these antiviral treatment, that is the acyclovir, valcyclovir, so this should be started ideally within first 3 days of onset of symptom. That means first 3 days are crucial to start antiviral therapy. If the Bell's palsy is diagnosed, the patient is having symptoms like 3 to 4 days back, and now on the 4th or 5th day, if we want to start the treatment, never give antiviral, because this is of no use. So antiviral should be given within 72 hours. And what rest? Physiotherapy, again it play a very definitely role, but physiotherapy, it should be started post 3rd day of the onset of the symptom. Never physiotherapy should be started in first 3 days. It should be given or should be started after 3 days of onset of the symptoms. Why I am stressing on these points? These points have been asked in the exam multiple times. So this is all about the medical treatment. You can give the supportive therapy to the eyes, like I'll give the eye lubricant, because there is dryness of the eyes, and dryness of the eyes may cause corneal ulceration, conjunctival ulceration, etc. So what we'll give? We will apply some lubricant drops in the eye. We will ask the patient to wear the glasses in direct sunlight, okay, to protect the eyes, okay. Now suppose this medical treatment doesn't help, so what next we can do? We can go for the surgical decompression. In surgical decompression, what we'll do, by using the drill, mastoid, we will drill out the mastoid one, and we will remove this facial canal. What? Facial canal is a bony covering outside the facial nerve. So what I will do in facial decompression, by the help of the machine or drill, I will remove this bony canal so that facial nerve can be exposed directly. So how it helps? It will give a facial nerve a better space to pop up, so that fiber will not get damaged. Okay, so what we'll do, facial nerve decompression. What are the parts we can decompress? Vertical part of the facial nerve, tympanic part of the labyrinthine segment. We know that labyrinthine segment is the narrowest part of the facial nerve, which is around narrowest and the shortest. And any viral infection firstly or most commonly affect the labyrinthine segment. So we can surgically decompress that part. Prognosis of Bell's palsy is very good. 90% of the patient recover even in the complete Bell's palsy. And suppose that this treatment is not helping either surgical or medical, what next we can do? We can use the nerve graft. That means the necrosed portion of facial nerve, we can just remove it and we can add another part of the nerve to make a continuity of the facial nerve. And what are the preferred nerve? The best one is sural nerve because thickness and the length is very good according to the facial nerve. But most commonly what we use now is the greater auricular nerve. Why this is most commonly used? Because greater auricular nerve runs in the neck just in close proximity to the facial nerve, or it is very nearby to the facial nerve. So it is easy for a surgeon to find out the greater auricular and use it directly without giving any other incision at any other site. I hope you got it. Now, this was all about Bell's palsy. Now comes to Ramsay-Hunt syndrome. These all syndrome has been asked in the previous years. So try to focus properly. Ramsay-Hunt syndrome, it is an herpes zoster infection in geniculate ganglion. Geniculate ganglion is the first gene. So sometime herpes zoster may get infect the facial nerve at the level of the geniculate ganglion. So what are the symptoms? Patient will have severe pain in the ear with the minor vesicles at the ear or the pinna. And there will be hearing loss. Hearing loss in herpes zoster oticus or Ramsay-Hunt syndrome may be conductive or may be sensory neural. Why sensory neural? Because this herpes zoster may affect the inner ear or the cochlea or the auditory nerve. So the hearing loss will be sensory neural or conductive. There may be the facial nerve paralysis because it directly affects the facial nerve, and there will be profuse ear discharge which will not get relieved by antibiotics. So we have to think if the patient is having severe pain with the vesicles of the pinna and patient is also having sensory neural hearing loss with facial palsy and a ear discharge which is not getting benefited with the help of the antibiotic, we must think of Ramsay-Hunt syndrome. And in that case, we have to give antiviral treatment. Treatment should be aggressive. If we are using acyclovir, so we have to use higher doses. And generally, this syndrome is having poor prognosis. But if the patient visit to OPD in first 1 to 2 days and we start the treatment, then prognosis can be good. Now, the other thing is Melkersson-Rosenthal syndrome. Again, examination point of view, important, asked in the exam. So, it is a triad of recurrent facial nerve palsy and patient with a swelling of the lip and fissured tongue. See, look at the diagram. That tongue is fissured and there is puffiness of the lips. You can see, and these lips become red. So in Melkersson-Rosenthal syndrome, how to remember this? See, look at the tongue, there is a rose. That's how I remember. So rose is red. So what happens in Melkersson-Rosenthal syndrome? The patient become red. There will be edema of the cheeks. The lips become red and swollen. Swelling will be there. And there will be fissured tongue and recurrent facial nerve palsy. So this is Melkersson-Rosenthal syndrome. Remember the triad. Tell me, what are the other causes of recurrent facial nerve palsy? Again, asked in the exam. So recurrent facial nerve palsy, other causes are Melkersson-Rosenthal syndrome. It happens in diabetes. It may happen in sarcoidosis or tumor. So sarcoidosis, Melkersson-Rosenthal syndrome, these are the causes of recurrent facial nerve palsy. Ramsay-Hunt syndrome, it is not a particular cause of recurrent facial nerve palsy. It may happen 2-3 episodes in this patient life, but generally recurrent facial nerve palsy causes are these much. Now, 4 diseases. Heel-Forot syndrome. What do you mean Heel-Forot syndrome? It is a uveo-parotid fever. What do you mean uveo? Uveal tissues are present in the eyes, like the iris choroid. All this muscular supply in the eyeball. So, Heel-Forot syndrome is a syndrome which is involving parotid gland and the uveal tissue in the eye, that is the iris or choroid. So, these uveitis will be there, inflammation of iris or choroidal tissue, and parotid gland will be inflamed. So, how patient will present? Patient will have bilateral parotid gland swelling with the facial paralysis because parotid is involved in facial nerve, runs in the substance of the parotid gland. So, there will be bilateral parotid swelling with facial palsy and uveal tissue inflammation. So, that is Heel-Furrow syndrome. Okay. Now the fourth one is synkinesis. Sometimes what happens is the facial nerve, any injury, so there will be aberrant re-innervation of the facial nerve. That means the facial nerve fibers will get attached to some other, they get re-innervated with some other structures. So that is known as synkinesis. So in that, what happens if suppose we want to use one muscle, like we want to smile. So if we try to do that, so some other muscle like winking of eye will be there. So some other muscle get contact. So that is synkinesis, aberrant re-innervation of the facial nerve. Now crocodile tear, asked 2-3 times in the exam. What do you mean by crocodile tears? So it's a gustatory lacrimation. So that means the patient, while looking at the food or while swallowing or chewing the food, patient will have tears into the eyes. How this happen? First you try to recall tears function is a part of the GSPN. That is the first branch of the facial nerve. So what happens? Suppose any facial nerve injury before the first branch emerges. So this GSPN nerve, the first branch of the facial nerve, which supplies to the lacrimal gland, sometimes it get aberrant regeneration. Okay, so it will get regenerated with some other part. So by looking at the food, so patient will have start tears in the eyes. So the lesion is before geniculate ganglion, and the pathology happens is aberrant regeneration of the greater superficial pectoral nerve. So it is known as gustatory lacrimation. That is by looking at the food or trying to swallow the food, patient will have lacrimation. And what is the treatment in all these? Whenever there is an aberrant re-innervation, the best treatment is to inject the Botox in that muscle. So what I will do, I will just inject my Botox injection over the affected area. Or rest, what you can do, Vidian neurectomy. So just incise the Vidian nerve. Okay. So this is crocodile tear. Now Frey syndrome. Again, examination point of view, it is important. So what is Frey syndrome? It is a gustatory sweating. Whenever patient is eating some food or trying to, so what happens? Lot of what? Sweat will be present over the face. So whenever patient is eating food, sweating occurs. So patient will say, will come in the OPD with a complaint. So like, sir, whenever I'm swallowing any food or trying to chewing the food, what happens is I got a lot of sweat over my face, over my neck. So how it happens? It is because of aberrant regeneration of auriculotemporal nerve with the sweat gland of the skin. So what happens is this auriculotemporal nerve get connected with the sweat gland. So whenever patient is chewing any food, so auriculotemporal nerve will get stimulated, and what it will do, because it is connected to the sweat gland, so there will be extreme or excess sweating. What is the treatment? Again, Botox is the treatment. So you have to inject locally the Botox injection. This is the drug of choice. And if this doesn't help, what we can do is tympanic neurectomy. Okay. So, and what is the test for this? Iodine starch test. So what is to diagnose the syndrome, Frey syndrome? What is the test? Minor test is the iodine starch test. So what is the prevention? It generally happens, Frey syndrome, while doing the parotid surgery. Suppose. So what we will do, how we can prevent? So we will put a fat or some muscle or fascia between the skin and the remaining part of the parotid gland or the remaining part of the muscles. So we will put a barrier, interpositional barrier like dermis fat or subcutaneous muscle. So this barrier will help this regeneration of the auriculotemporal nerve with the sweat glands. What is the most common iatrogenic injury to the facial nerve? Iatrogenic injury, that is the parotid surgery. Now, temporal bone fracture, again important cause of facial nerve paralysis or facial nerve injury. There are two types of temporal bone fracture. One is the longitudinal fracture and other one is the transverse fracture. I'll make you understand with the help of the diagram. See, look at this diagram. This is my skull bone, okay, and this is the long axis of the temporal bone. We know the petrous part, long axis of the temporal bone. Now, this is my longitudinal fracture. Longitudinal fracture is running along the long axis of the temporal bone. This is my longitudinal fracture. This has been marked here. Okay, so this is my longitudinal fracture which is running along the long axis of the temporal bone, showing in the diagram. Okay, so this is the most common type of temporal bone fracture. How the impact is? Suppose patient by get a road traffic accident. So impact is from the lateral side. from this side, from the temporal bone side. So the fracture line will run along the long axis of the temporal bone. This is most common. 80% of the fracture in the temporal bone are of longitudinal type, and patient generally present with an ear bleed, a perforation in the tympanic membrane, hemotympanum, that is a collection of the blood in the mastoid or the tympanic cavity, with conductive hearing loss, maybe because of the hemotympanum or maybe because of the ossicular chain discontinuity or disruption. Because the impact will run like this, so there may be medullary pathology like blood clots or ossicular chain disruption. So longitudinal fractures are 80% fracture presented with a bleeding, conductive hearing loss. But in this fracture, the chance of injury to the inner ear are very less, and chance of facial paralysis are 20%. That means less chances of facial paralysis. So prognosis is comparatively good. Let's talk about the transverse fracture. So this is transverse fracture. You can see the line of the transverse fracture. Okay. So this is just intersecting the long axis of the temporal bone. You can see if I demarcate my long axis of the, this is my long axis of the temporal bone. So this is like 90 degree or perpendicular or intersecting this temporal bone. So this, what is the impact of the injury? Suppose in rotator patient get injured from the frontal part. So impact is like from the front or from the occiput, from the behind. So in that case, patient will get the transverse fracture. It is less common, only 20% cases will have transverse fracture. But look at the line. It is involving the inner ear. In transverse fracture, the part affected is the otic capsule, inner ear or the facial nerve. So it is more dangerous because the facial paralysis chances increases to 80%. The chances to injury to the inner ear or optic capsule increases. So there will be sensory neural hearing loss. Patient may have vertigo or giddiness or other symptoms. So symptom-wise transverse fracture is more severe. Prognosis is relatively poor, but the facial paralysis chances increases to around 80%. So that's how I hope you can understand about longitudinal and transverse fracture. This is another diagram showing the this is my longitudinal fracture. You can see along the line. This is the fracture line. So this is sparing the nerves here. This is sparing the nerves here or the otic capsule, and this fracture line going like this. Okay, and it happens. What happens in the transverse fracture? The fracture line it just affect the inner ear or otic capsule.